I would like to introduce Heidi Robertson Cooper. She will be our speaker today. Heidi is the owner of HRC Healthcare Advisors, and she's been helping us for the last couple of years develop the Kansas Care Network and just negotiate all the ins and outs of value-based care, value-based payment. So at this time, I'd like to turn it over to Heidi.
Thank you, Terry. Hi, everyone. Good afternoon. Excited to be with you all today. Let me get my large water bottle situated here. Okay, so as Terry had said, we have kind of a two-part session today. First part is really digging into the pay for quality programs that the 3 MCOs have active that are available to your health centers and other practices around the state. So this is actually a continuation of a session that we did last month, and it's part of a broader series. We're calling it the Value-Based Care Forum, which is a series of trainings. This is the only live one. The rest are virtual, where we are aiming to have very practical information, education, and connecting with your peers around building your capacity as a health center in value-based payment models. And so we have about 7 sessions in the series. This is number 3. So we'll do a quick recap of what that last session looked like, and then we'll go ahead and jump in to this particular session. So let's go. Okay, so as Terry mentioned, she already kind of ran through this. And just a little bit about my background. As Terry had mentioned, I have been working with the Kansas Care Network for a couple of years now, helping build the network into a clinically integrated network. So a lot of what I do, not only with Kansas, but also with many states around the country, is I work with primary care associations and health centers, wherever they're at in their value-based care journey. And help them build capacity and perform so you all can bring home more dollars to support your mission. Today, we're going to be essentially breaking down those pay for performance or pay for quality programs that we reviewed in the last session. We're going to talk a little bit more about how you actually earn the dollars that are available to your health center, how the mechanics work, because they're all different, because MCOs, for whatever reason, can't align. And so we'll talk a little bit about that. We're also going to talk about how performance is calculated on these measures. So we're going to get kind of in the weeds. And then last, we're going to talk a little bit about simplifying this as much as possible with 3 MCOs, with 40 quality measures, plus you will have UDS and grants and other measures that you're looking at. We're going to discuss a strategy on how to really kind of identify the high yield activities that your health center can leverage in order to earn as many incentives as possible, but still being true to your mission. One other thing I want to make sure that you all are okay with, I'm okay with questions as we go through the session, so we don't have to wait until the end. And I think if you have a question, Maria will be Maria and Trish will be running around with the microphone, so just raise your hand and we'll get that to you. So feel free to raise your hand at any point in time. Okay, so in our session that we had last month, we looked at the 3 pay for quality programs, one from Sunflower, one from Healthy Blue, and then also one from United. These are all available to your health centers. You may actively be participating in them currently. 2 of them, Healthy Blue and United, you don't have to sign anything. It's just something you're participating in, and they probably are knocking at your door, wanting to meet with you. And so that happens a bit passively. For Healthy Blue's program, you had to sign a letter of agreement to participate. And so that is how you would know if you're participating in that program. So we ran through what those are. We talked at a high level about the constructs, and we also spent some time talking about how these programs came into existence and the role of KDHE and CanCare, kind of setting that strategy, and essentially how the state is responsible for reporting quality measures to CMS. The state is also responsible for setting the strategy for the MCOs in terms of the quality measures they have to report, and also kind of setting the benchmarks and also withholding dollars from the MCOs in order for them to perform as an incentive for the MCOs to perform. Why we covered that, it's important for you all to understand, is that essentially activities at the state level are being pushed down to you all through these pay-for-performance programs. And as we know, healthcare is increasingly getting more complex. Costs are not going down currently, and quality will always be something central that will be focused on. The efforts of the state will likely ramp up compared to your peers or similar to your peers across the country. And so why that's important to know is that in these pay-for-performance programs or any programs that may be coming from the MCOs in future years are really going to be driven by the state. But you all as health centers and primary care providers are the ones that can actually render the services that the MCOs are being held accountable for. And so I think it's just important to understand that a lot of this may feel like it's happening to you, which it is, but we'll be talking about some strategies on how to take a bit more control of that and be smart around how you structure internally, but also how you think about this work, blending with some of the other work that you're already doing. And then the last thing that we really touched on was just some key vocabulary that is really kind of it's in the value-based payment realm, and you may not hear it as a health center and in other work that you're doing with quality. And so we became familiar with some of those terms like attribution, risk adjustment, and of course, incentive payments. So that was a bit of what we discussed in the last session. So now we're going to hop into more of the content that gets a bit deeper into what each program looks like from an incentive structure basis and what that means for your health centers in terms of performance and what to think about in order to kind of earn those incentive dollars for your health center. Okay, so this, you'll have access to these slides, but this here is kind of a matrix of the current value-based payment or pay-for-performance programs from the 3 MCOs. So just as a reminder, UHC has their PCPI program. I always get that acronym wrong. Trish, I will get it right one day, I swear. I'm always asking her, what is the acronym for that? But essentially, this is a pay-for-performance program. There are a list of quality measures, and if your health center meets that quality measure, you will get a payment for closing that gap. And so we kind of call these like a pay-for gap closure type of payment. So it could be $25, it could be $75, but they're paying your health center for that activity. We have Sunflower. Sunflower has a couple of different programs that your health center, again, is automatically opted into. So these are at your disposal, same as the UHC one. They have one that's called the Continuity of Care Program. This is fairly new. We're seeing this really by Sunflower and its kind of peer plans across the country to really start looking at risk adjustment. And what that means is that essentially the health plans are paid a premium from the state to administer their programs. That dollar amount is dependent on the complexity of the patient population that they are covering and managing the care for. How they determine how complex that patient population is through coding. which happens at a visit at your health centers. And so this is really big in Medicare Advantage and in Medicare, if anyone's participating in the Medicare Shared Savings Program through an ACO. It is starting to hit at the Medicaid level. And so what Centene National has done, as well as Sunflower, they've implemented a program called the Continuity of Care Program. And essentially, they are going to pay your health centers to complete what are called appointment agendas. And what these are is essentially kind of alerting you to either open diagnoses that maybe are on a claim for previous years and aren't showing up in this year. And so alerting a provider to, hey, they had diabetes last year. Let's make sure they still have it, or if not, let's resolve it. Or if they're, if they are an amputee, making sure that carries over into the new performance year. And so they have a program incenting the completion of those documents. So that one is kind of a one-off, but you're probably hearing about it from their quality improvement staff. They also have a pay-for-performance program, a little different from UHC's. This one, they pay out essentially what's called a per member per month payment. It is not paid monthly, so that is misleading. It's more about the amount that would be paid out. And we'll talk a little bit about that in some future slides. But essentially, you have to meet there are quality measures, you have to meet a certain target. The higher your performance, the higher payout you get. For Healthy Blue, they have their PQIP, their Provider Quality Improvement Program. It's a program that is very similar to the one I just described with UHC. Different measures, of course, but it is paid out through targets. So there are 2 targets from a performance standpoint. There's a lower target. If you hit that, you get also a per member per month payment. And then there's a higher amount associated with higher payments. And then last, Healthy Blue also has a social drivers of health value-based payment program, which is really leveraging assessing their members for health-related social needs, and then also closing the loop on any of those needs that have been identified when you were able to close the loop and meet that need. Great in theory. There's just a lot of practical implications that make that tricky. But this is kind of the universe that we're working with today. Each program, unfortunately, is different. I'm going to tell you where there's alignment. There's a lot of detail in the next coming slides, but my goal is to help you walk away from this session with understanding where the alignment is and how to think about these programs in a way that makes sense for your health center, as well as to actually earn some additional dollars that aren't restricted, that you can use for any patient regardless of insurance type. Okay, so for our pay-for-performance agreements, it's important, I think, for you to understand, again, a couple of terms here. So attribution, one big thing, and when I started at a health center years ago, I'm not going to age myself, attribution was just wild to me. Where for UDS, we knew exactly who our patients were. We knew who we were measuring. We knew if they met the denominator. We knew if they, met the numerator or not. Like, we knew where we stood. With value-based payment programs through the MCOs, your universe is much larger. Yes, these are patients you've seen, but they're also patients who have been attributed or assigned to you, which again is another CMS requirement. But essentially, this is the universe that you are being evaluated against. And so when you look at performance, you'll look at your UDS performance and you'll see your cervical cancer screening outcomes. And then you may look at a performance report from the MCOs and you'll see very different numbers, likely much lower. Because in that denominator, you're going to have patients you've never seen that are probably not being seen anywhere. but it is an opportunity to attract new patients with a favorable payer source. And then it's also good to be aware of this, because if you're going to compare UDS to some of your MCO performance outcomes, they're going to look different and it's going to be lower. So that's one thing that I think right off the bat when I started this work, I really had to wrap my mind around. And I still, like 10 years later, still struggling with it. But it is critical to know who is attributed to your health center, because that is the basis for any of the pay-for-performance opportunities and then any more sophisticated opportunities that may come your way. Every pay-for-performance program has a measure set. There are benchmarks associated with that. So for UHC, that's kind of the exception. They're saying if you complete a well child visit, we'll pay you $25. If you complete a cervical cancer screening, you get $75. So that is kind of, they're standing out there on their own with that, and that is much more straightforward and easier to kind of calculate what the upside could be for your health center. For for Sunflower and Healthy Blue, they've made this really complicated. So they have benchmarks and targets for each one of their measures. They use national targets set by NCQA. So how many of you are familiar with Patient Centered Medical Home and everything that comes with that and the big process? So health plans have to do that too. They have to go through an accreditation process, and NCQA essentially looks at all data across the country on Medicaid plans, commercial plans, and they set percentiles for performance. And so KDHE, the state, CanCare, has said, we are, as a state, working towards a particular percentile or benchmark as a state. And so these the MCOs have said, okay, this is where they want us by 2027. We're going to set our benchmarks where we think we can incrementally get there. So our performance or our premium withhold is something we can get back. And so the benchmarks are going to differ between measures, and we'll talk about that a little bit. But there's a methodology behind those particular benchmarks. And it is based off of national standards, not necessarily how Kansas is performing. And we will talk about that in a moment. Reporting timelines. Each program has kind of a different flavor on how you report. They satisfy the measure by claims data. Some will asked to come to your health center and look through your EHRs to see if there's any clinical data in there. They can close the care gap. And there are other different mechanisms. I would say some data is flowing to the health plans through drives for those health centers that have opted into that. And so there's multiple ways to submit data, but there's also different reporting timelines. So one plan might pay out quarterly. The other one might pay out right after the performance year ends. And then we see others that pay out maybe 6 to 8 months after performance year ends. They're all very explicit around what that payout timeline looks like and what data is accepted to meet the measure. And then last, we talked a little bit about this, but the incentive types, is the pay, there's the targeted approach where you get a part of a PMPM that is then multiplied by your entire patient population. And so if you see like a 30-cent per member per month payment, if you meet the target, what that really means is that you get 30 cents per attributed patient times 12. And so just to kind of break that down, you're like 30 cents, not great, but depending on your patient population and how many patients are attributed to your health center, that multiplies very quickly. Okay, so that is kind of I would say the nuts and bolts of like what a program looks like. So let's talk a little bit about the quality measures. So I'd mentioned earlier, the quality measures are really pushed initially starting at CMS. They have core Medicaid sets. They have one for pediatrics. They have one for adults. Each state Medicaid program is required to report annually to CMS. And so CMS is not yet tying performance to any payments, but I can absolutely see a world where that's going to happen, unfortunately. And so where the state comes into play is they are setting their preferences on the quality measures that they see as a state agency that performance really does need to improve because it's tying to the quality outcomes of Kansans who are covered by Medicaid. And so they are mainly HEDIS measures. And so think of HEDIS measures kind of like UDS measures, except that HEDIS measures look at patients or members tied to insurance status. And so with UDS measures, these are patients that come in to your health center. You've seen them, so you know them, you have a relationship with them. With HEDIS, this is essentially who is being covered by that health plan, and they are then eligible to fall into potentially the denominator of a measure, depending on the measure. And so UDS, like when you think about performance, that's how HRSA is looking at your performance as a health center. With HEDIS, think of this as how CanCare is evaluating the performance of the MCOs. And again, the MCOs don't deliver care. They don't render services to patients. That's where your role comes in, right? And so that is essentially kind of the trickle of how those measures work. There are probably hundreds of HEDIS measures. The core set that's actually in the Kansas quality measure report, QMS, the quality measure report. It happens annually. But essentially, they outline the measures that the MCOs will be focusing on with the targets. There are quite a few measures in there. From a health center standpoint, these are the measures that you're likely going to see and that are currently in the pay for quality programs that are available to your health centers. So they're preventive, they're PEDS focused. We see a lot of well child visits. There's some chronic disease, slightly limited because of the population is more pediatric than adult. We have some behavioral health measures, not a ton in the pay for performance programs, but there are a couple. There are utilization and access measures. So this can be how a patient is utilizing the emergency room or inpatient visits, or this could just be access to primary care services. And then we're seeing, I don't know how long this is going to last, but all the MCOs have either a screening for health-related social needs, or submitting Z codes that are tied to some of those screening outcomes. And so there has been an emphasis on that in some of the pay for performance or pay for quality measures. So this slide here is a list of all of the measures that are in the 3 pay for quality programs that are available to your health centers now. There's a lot. When I was working at a health center, we made a laundry list of all the measures that we had to think about, either perform and track through our quality improvement program, obviously UDS, but then we had this influx of measures from the MCOs. We also had grants we were trying to perform towards and had certain quality measures we were trying to move there. And then we also had our internal QI efforts that maybe it was more process-based, but it was something we were paying attention to. And so while this is just the MCOs, you all have plenty of quality measures that you are already focusing on. And so it is impossible to do what you're already doing and required as a health center and to truly focus on all, I think, 20 of these measures. And so I just want to say it's okay if you feel overwhelmed. And we're going to talk about some strategies on, how you just can't do it all, but how you can get hyper-focused and focus on those high yield measures that span payers, that also have maybe higher incentive targets, or that you're confident that you can meet those targets and earn incentive dollars. So this next slide, this is what I call a measure matrix. This is what we did at the health center that I worked at. And this is what I do with a lot of my clients is like, we just need to start and we need to figure out how we're being measured. I usually come in around value-based payment. So I'm looking at agreements that they have executed with the plan. So right here, we are just looking at the 3 MCO pay-for-performance programs. You might have Medicare Advantage programs that you're participating in. You might be in a Medicare Shared Savings program. But right here, we are looking at the MCO HEDIS measures, and I threw in UDS. And so what this activity does, it essentially allows your team to sit down and think about how are all the ways we're being measured, because it's coming from every direction. And you want to create a laundry list of what those measures are. And then you want to identify who's holding you accountable for those measures. And then you want to identify, okay, I'm seeing X's in multiple rows here. Perhaps that's one we should have a focus on because it meets UDS, and all 3 MCOs are focusing on it. And so you'll see here a bit of that kind of stratification. The dark measures are those that either span all 3 MCOs or include UDS and are what are kind of a high yield measure. So for example, well-child visits, every MCO at some level is holding you accountable for this measure. We all know how hard it is to get those kiddos in for those visits, especially when they're younger or even when they get older. And so what I think is important about how we look at well-child visits is that it's an opportunity not just to check the well-child box, but you can touch many of the measures on this list within a well-child visit. It's kind of like the Swiss Army knife of activities that you could do for a patient, a pediatric patient, because you can check so many boxes. And so the well-child visit can check that box. It can check immunizations. It may check chlamydia screening, depending on the patient. You can do your nutrition and physical activity counseling. So you're checking UDS box there in addition to the MCOs. And given the pediatric population that is predominantly covered with Medicaid in Kansas, it is just a really great entry point for focused efforts around value-based care. And obviously, it's great for not only the patients, but the families as well that you serve. So you can see here that not everything is highlighted, and there may not be a world where we focus on everything that is highlighted here. But the goal is to go through the activity, pull in every single measure that you have, and conduct an analysis to see, okay, what does this list look like for us? And it gives you the time and the space to start thinking about, okay, where can we focus our efforts? Where do our grant programs align with these particular measures? And how can we look at it a bit more holistically so we're not killed by initiative overload? Because we all know as health center people that happens very frequently and all the time. Okay, so next I'm going to shift to incentive structures. And so we talked a little bit about all the measures that are included on these programs. And so let's talk a little bit about how you can actually earn the incentive dollars tied to these programs. So I've broken it down with the 3 different MCOs. Sunflower has the bonus payment per quality measure. And so if you reach the first tier, you can get a payout for that particular quality measure. There is a cent amount, I shouldn't say dollar amount associated. It ranges from like 30 to 50 cents per measure. But again, if you hit the first target, it's probably a lower payment. If you hit the second target, it's a higher payment. And again, the per member per month means if you hit the target, you get paid out for the entire attributed patient population. They don't have to qualify for the measure. It's the entire attributed patient population. And it would be the amount of that incentive, so let's say 30 cents, times 12. And so as many measures as you can hit there, you just rinse and repeat that formula. And so Sunflower should be in their portal providing you with lists of who these patients are, who has open care gaps, who needs to be in for a visit. How many of you all access your Sunflower portal for this information? Yay. Okay. How many of you are like, what portal? How many portals do I have to log into? Yes. Okay. So agreed, there are too many portals. But Sunflower has this information for you. If you don't want to log into any portals, you could reach out to your quality improvement advisor. They all have different names, but essentially they can provide you with that targeted information. So you know who's attributed to you, you know who's eligible for those incentives, and really what your upside opportunity would be. So for UHC, again, this is still pay for performance, but it is pay per gap closure. So if you conduct a well child visit, you get $25. If you conduct a cervical cancer screening, you receive $75. I'm not sure if those are the amounts tied, but it ranges from $25 to $75 in terms of how they're paying that out. The kicker with UHC is they love everything to be included on a code or on a claim. So what that means is that you have to make sure your claims include the appropriate codes so they can close that care gap and then pay that incentive. And so UHC does not like to deviate from their standards, unfortunately, but we did hear a little bit of wiggle room on that potentially for this year. And so I will say they're sticklers on that, but there could be an opportunity at the end of the year maybe to have a bit more flexibility around the data that they'll accept to see if that care gap was closed. And then Healthy Blue, again, very similar to Sunflower. You will have 3 different performance targets. There is a low end and then there is a high end. And you have to meet at least the 50th percentile. Again, we're looking at kind of national numbers here that NCQA sets. But you would get paid out on that particular measure. Again, a PMPM, so it'd be 25 cents is one of the common ones. And again, if you meet that 50th percentile, you get 25 cents, and then you would be paid out on your entire attributed patient population, times 12. So not just who's eligible for that measure, the entire attributed patient population. So there are some things that we're seeing, at least in terms of how 2 of the MCOs are aligning their incentives and providing kind of that stepping stone benchmark to higher payments. Okay, so this just digs in a little bit more on this concept. I think the thing that I want you to take away about this particular slide is that other than UHC, Sunflower and Healthy Blue require you to at least meet a minimum benchmark. And these benchmarks aren't a joke. I'm going to say I was looking at some data this morning. I was looking at how the Kansas population that's covered by Medicaid have performed last year. And CanCare has some really ambitious goals. And you're going to feel that in these particular pay for performance or pay for reporting agreements. And so one thing to know is that the MCOs are trying to move the needle because they are being held accountable by the state, and that's trickling down to you. And so when you see the benchmarks and where you may stand currently, what the data that you may have, it's probably just 6 months if you're looking at any of your payer data, because there is a claims lag. And so we're probably looking at data from through June. So you have a big opportunity of the rest of the year to kind of get to where you would need to be to meet that first benchmark to bring home a payment. But it is, as you perform higher, the dollar amounts go up. So that opportunity increases financially as your performance increases. So that is something I think that's important to note, but also makes it a bit more complicated to understand, like, what is your potential earning from a pay for reporting or pay for quality program? Because ultimately you want to know, okay, what can we, if we put so much effort towards this, like, what could we bring home? Is the juice worth the squeeze? And so with the tiering system, it does make it a little bit more difficult to do that easily. As with UHC, you can do that pretty straightforward with some math, as long as you know how many patients are attributed to you, and then how many kind of would fall into those general categories of the particular measure. So on this particular slide, this gives a couple of examples of how this kind of works in practice. So we have the PMPM that is paid out. Again, you have your targets. You have a targeted threshold. And then for Sunflower, you have 3 targets. They are tied to those NCQA percentiles. And then based on your performance, you can then earn the associated PMPM for your entire attributed patient population. So for that, you'll see, okay, we have a 30-cent PMPM for this particular measure. We have 1,000 patients attributed to our health center from Sunflower. And so we've met that threshold. So now we are eligible for 30 cents for our 1,000 patients, which would be around $300 if you just look at 1 month. And then if you multiply that by 12, that gives you the payout for that particular measure. Again, there are probably 10 measures in their particular program. So you would just rinse and repeat that particular method to figure out where you would land in terms of payment. We talked a little about UHC and how they're paying for care gap closure. And then for Healthy Blue, it is essentially the same as Sunflower. They just call it different things. So Healthy Blue calls it like partial credit, which is essentially just a lower PMPM payment if you meet a lower benchmark. If you meet a higher benchmark, it's the full payment. So it's just the terminology that they've decided to use in order to maybe motivate you to perform in a different way. So you can kind of see here how these could potentially calculate out based off of the associated PMPM, the number of attributed patients times 12. Okay, so this just goes a little bit deeper into Sunflower. So I will say, when you look at Sunflower's, their PMPM opportunities, it's a little sad. When you see 15 cents like per member, it's like, that doesn't seem great. If you have a large attributed patient population, yes, that multiplies really quickly. But let's say you're kind of a smaller health center and maybe you have 300 patients attributed to you. That doesn't add up really quickly, as you all can probably figure out. And so one of the things that we'll discuss after I wrap up these next couple of slides is, how do we make the decisions that we need to so we're not wasting time and we're developing a strategy that enables our health center to not treat this like a separate initiative, but it is incorporated into all of our quality work that we're doing. So whether it's, you get a check from Sunflower for your pay for performance results, you're also working towards Healthy Blue, but you're also working towards overall population health within your health center. And so again, depending on attribution, like, the numbers may not be there for this to be enticing to you or your health center. But I think that's part of the analysis process that you all will need to look at. And I think the next thing that I would say is that, generally speaking, and we'll talk a little bit about this in the next session, pay for quality and pay for performance, like, that is not really where the big money is in terms of value-based payment. And if you're thinking about how you really want to kind of supplement your health center's revenue, pay for performance isn't really the thing to do that. It gets into more of the shared savings opportunities and more complex payment arrangements that is founded on this work. You have to meet quality measures in those programs, but the upside is much greater. And so with these programs, it's giving you a good base because you can't earn shared savings without meeting quality thresholds. But it's not going to bring you a significant amount of revenue. And I think that's important for your health centers to understand as you're weighing your internal strategy on measures you want to focus on. So this is an example for the UHC program. Again, this one's much more straightforward. We're closing care gaps. You're getting a payment as long as you have the appropriate code on that claim. And so you can see here with the math, I think this one might be a bit more lucrative, but again, it depends on your patient attribution size and how many you're actually kind of closing that care gap for. One thing about the United program is that they also include attending the an echo series. So if your providers or clinicians at your health center attend those, if you submit the documentation, of course, you can get paid for that. So they're kind of trying to be a bit more well-rounded instead of just tying it to the HEDIS measures. Okay, and then for Healthy Blue, and this is again similar to Sunflower, it is important to know that if you do not meet their lowest benchmark threshold, you don't get anything. And so you can be putting in a lot of work and you may not see the fruits of that depending on what your attributed patient population looks like, how you engage that population to get in for a visit. And so it really does come down to understanding who that group of people are, how many of them you've seen in your health center, and what the opportunity is to pull them in. Because again, we're looking at a broader universe and less of the patients you've seen, but those of patients or members that you are accountable for in these programs. So as we mentioned, there are 3 MCOs. You all are very aware of that. That's how Medicaid pays you. I feel like Kansas, I'm from Missouri, so I'll lump Missouri into this, is fortunate that you only have 3 MCOs. Michigan has 8, Kentucky has 7, Texas has in the teens, it's absurd. So I'm just gonna preface that it could be worse. You could be managing 10 measure sets. So know that. I will also say that it still doesn't make it easier, especially if the MCOs are being held accountable the same way and they have different measures and are weighting them differently and paying them out. It's a lot to figure out and it's a lot to manage internally if you want to have concerted efforts towards this type of work. And so as I had said at the beginning, it's impossible to do it all, and I feel like you should be okay with that. And part of this discussion is talking about how do we make the decisions? How can we really simplify as much as we can while still trying to make progress here? Because ultimately, this is new revenue to your health center, and you all know better than anyone, times aren't great to be running a health center, let alone being in healthcare right now. So any additional dollars could really help any patient that you serve, especially if they're uninsured. So while it does take some planning and some strategic thought around how you want to approach it, you can absolutely do it if it's something that's important to your health center. And so I think first is the health centers that I work with, it's often that I learn that they don't know what programs they're participating in. They hear from MCOs, they hear from Sunflower, or they hear from, Molina, or, some MA plan, and they're like, yeah, they keep calling us. They want us to do these things, but I don't really know what we're supposed to do or what, the measures are. And that's super common because as you all know, you probably have 20 different payers, probably more that you're accepting insurance from, and they all have their own flavor of value-based care to some degree, right? And so you can't participate, you can participate in 20 value-based programs, but it's impossible to manage that load. And so it's important to understand what programs are even available to you and that you've signed the line on or have been automatically opted into, like Sunflowers and United's, and then those that you may have executed an agreement with that does have some pay for performance or other types of arrangements. So it's really important just to have a baseline to know where you stand and all of that. Next is create a crosswalk, and I've got some examples here. I showed you the measure matrix, so I think that one's pretty straightforward. It's really just identifying every single measure that you are trying to put some effort towards and improve. For this exercise, it's a bit more complicated because you may have to get out your payer contracts. You may have to pull out your Healthy Blue, your Sunflower pay for performance guidance to understand, okay, what is it? What is this? Which payer? Is this a pay for performance? Is this a shared savings? And so it will take some work to truly figure out where everything stands and what your health center is participating in, as well as getting it down on paper. But it is the way, I think. There's probably multiple ways to go at it, but it is a good way for a small group of people to kind of sit together in a room and understand what the depth of this is for your health center. And then the last is kind of assessing where you're at. So once you have it on paper, you've probably received some scorecards or payouts in previous years. Maybe you didn't know where they came from. That's super common. Or why you got a bonus payment. That's also common. And so what you want to do is you want to look at, after you have your agreements laid out and you have kind of how those incentives can flow to your health center, you want to look at how you performed previously. You also want to be able to look at what the opportunity is and identify the gap. It's going to be impossible to hit 100% on these measures just because, for the MCO standpoint, it's a broader universe. And we know that health centers across the country can engage with this population between 50 and 80%, depending on the state. And so there's always going to be patients that you aren't going to be able to reach. And that is part of this, unfortunately. But what's important is that once you can identify how you performed last year, what the potential upside opportunity is, then you can start thinking about your strategy. Is it, okay, our payer mix is predominantly Medicaid, and we want to grow that. So we're going to focus on our Medicaid contracts and our pay for performance measures associated with that. We're going to look at how we performed last year, the checks that came in. We're going to look at our scorecards. We're also going to look at this year to see, has attribution changed? How have the measures changed? How are we reporting? Or how's our performance looking? And identify what is feasible to close that gap on what you earned last year and additional dollars that are available to your health center. So this Excel spreadsheet, I don't think it's on the app, but we'll make it available to you. What you're seeing here is essentially the 3 MCO pay for quality programs up top. I've done that work for you. And then at the bottom are examples of Medicare. If you're in an ACO, the Medicare Shared Savings Program, that's going to look different. This is showing a health center that is just not participating in an ACO, so they're just getting your PPS rate for your visits. There's no upside there. And then this health center has a commercial agreement with Anthem. It's a shared savings program. They also have a care coordination fee, which really aren't that normal anymore, unfortunately. And then it kind of explains how they can earn shared savings. The one below it is Humana. They have an agreement with their Medicare Advantage plan. small group of patients, and it's a shared savings program. So this gives you a sense of what that contract analysis can look like by listing every value-based care program that you're in. For this next slide, this is where we get to that opportunity analysis. So it takes it a bit deeper. And again, you're going to have to hunt around for some information here. But it shows for the sunflower program, again, kind of pulling from that above slide, is that what they have currently, what they got paid out last year. So in 2024, they earned $7,200, like not a huge check, right? They have a small patient population. And so when they did the math, they were like, okay, if we can move up to the second target, the higher target in 3 measures, that might get them $2,400 extra. Again, not a ton of money. But the potential value of that program could be $12,000. So the idea here is not to get you excited and be like, there's huge money in this contract, let's go do it. It's more around how do we think about this work and try to decide how impactful we were last year and how can we improve in the current performance year, and be thoughtful about, is that juice worth the squeeze? So I'm going to pause there. Again, this will be available as well in Excel format. I have 1 minute left, so I'm going to wrap it up. Are there any questions while I give you your next steps? Okay, so wrapping up, today we talked about how we have 3 different MCO pay-for-quality programs. They're all very different. There are some aligned measures. There are about 5. That is a great place to start. You need to understand kind of how your performance there is impacted by attribution and how you see those patients. And really, we're getting into session 4, which will be happening next month. And we're going to talk more about data and using your teams to impact these numbers. So make sure you have that on your calendar. But really, the big takeaway here today is understand where your health center currently is, not just with the MCOs, but with all of your value-based payment agreements. See where you're at, identify where that low-hanging fruit is. It may just be Medicaid, and that's fine. You might be in a ACO, adding that on there too, but getting really focused on the right measures that are going to move the needle for the most patients is going to be kind of the biggest takeaway here. And I've seen it work in a lot of health centers. You just have to have the time to put forth to it. So with that, we're going to wrap up. We can take some Q&A. We're going to take a little break before our next session.